Good morning, everyone. Welcome to this Department of Medicine Grand Rounds, May 4th, 2022. It's my privilege to begin the Grand Rounds this morning with an announcement, and we'll have a brief series of announcements. This has been the first Wednesday of the month, our hybrid Grand Rounds. We have a nice group here in person, and welcome to everybody online. My name is Ron Watellis. I'm the program director for the Internal Medicine Residency Program, and we'll start with the first announcements this morning, which is about our 2023-2024 Medicine Chief Residents. But before we get to that, I want to take a moment to first acknowledge this year's group of Chief Residents, who you'll be hearing from in just a moment: Jessica Busey and Achut Patil, Zach Ray, and Gabriella Spencer-Bonilla. They've been a superb group, have really led the program and been leaders of the department in what at times has been a trying year, but they've done so with tremendous professionalism and skill, and I want to thank them. All four will be staying here as part of the Stanford family. Jessica will be an academic hospitalist at the Palo Alto VA. Achut will be a pulmonary critical care fellow. Zach will be an academic hospitalist here at Stanford, and Gabby will be a cardiology fellow here at Stanford. I also want to remind everyone that in just about a month, we will be having our next group of Chief Residents, the 2022-2023 Chief Residents who you see here, who we look forward tremendously to working with. They're an incredible group: Peter Conan, Christine Santiago, Elena Vasti, and Sarah Waliani. Now, I'd like to take just a couple of minutes to tell you about the next group of Chief Residents who we just recently chose from among a terrific class. And you see the four of them on this very festive slide. And I just want to tell you a few words about each. So Ankita Devareddy earned both her BA and MD from Northwestern University, where she was really a star student. She graduated with induction into both AOA and the Gold Humanism Honor Society. We were, of course, delighted when she matched with us here in 2020. And as a resident, she's really charted a remarkable trajectory in multiple domains. Her clinical reviews have been consistently superb. She's been a leader as an elected representative to our Committee on Residency Reform since intern year. And she's been an active researcher with multiple investigators in cardiology, including Drs. Matt Wheeler, Raj Dash, and Fatima Rodriguez. She presented her work with Dr. Wheeler examining disease progression in hypertrophic cardiomyopathy at ACC. And from that work, she won one of this year's awards at the Residency Research Symposium. Ankita is a relentlessly positive force who makes everyone around her better, and we look forward to her making all of us better as one of our Chief Residents. After her chief year, Ankita will plan to pursue fellowship training in cardiology, possibly followed by subspecialization in advanced heart failure. Mugdha Joshi, Mugdha earned her BS in biology and AB in anthropology from the University of Georgia, graduating summa cum laude and earning a host of honors and scholarships. She then enrolled in Harvard Medical School, where she was active working in quality improvement and decision support projects, and during which time she had a superb academic record. And as such, we were delighted when she matched with us back in 2020 for her residency training. And here, Mugdha has continued to be a leader and innovator like Ankita. Mugdha has been an elected member to the Committee on Residency Reform since her intern year. She's been a member and project co-leader of Stanford Healthcare's Residency Safety Council, and she's done innovative work focusing on Volt communication and how that can be done better. And through that is an associate chair for the Stanford House Staff Information Technology Enhancement Council, which goes by the delightful acronym HITECH. She's worked with Drs. Angela Rogers and Andrea Jonas studying risk factors of prolonged intubation in COVID-19, which was recently presented at the American Thoracic Society annual meeting. And you can always count on Mugdha to look at any system and ask how it could operate better, skills which will serve all of us well during her chief resident year. And Mugdha, too, currently plans to pursue cardiology fellowship after her chief year. Balu Pai earned his BS in chemistry from Clemson University, graduated summa cum laude. And he then enrolled at the Medical University of South Carolina for medical school, where he was a true superstar, graduating with first honors and as a junior AOA member, an organization he was also president of in medical school. We were, of course, thrilled when he matched with us in 2020. And as a resident, he has continuously impressed and wowed us with all of his encyclopedic knowledge. never more on display than as one of the award-winning members of this year's ACP Jeopardy team, which made it just over the weekend to the national finals. Yay! And his enthusiasm is really limitless for clinical medicine. He has a strong interest in medical education, and he created and implemented an IRB-approved study testing the feasibility of small group spaced learning course in ECG interpretation. And you really can't spend any time around Balu and not be excited about medicine, and we can't wait for him to share that excitement with the entire residency class during his chief residency year. And after chief year, he too plans to pursue cardiology fellowship. Don't worry, Sarah is not, with a likely ultimate career goal in interventional cardiology. And last and certainly not least, Sarah Talamantes, who earned her BA in biopsychology from Cornell University in 2015, where besides being an academic star, she was a shooting guard for Cornell's Division I NCAA basketball team. Somehow on top of that, she also spent 3 summers working with the University of Colorado's Cancer Center as a clinical research student intern. And her research in, her interest in clinical trials continued, and she worked for a year after graduation as a clinical research coordinator at the University of Colorado Cancer Center before enrolling in medical school at Northwestern University. She earned her MD in 2020, and though I know this is a theme, she was an absolute star in medical school, earning induction into AOA and working on research examining the relationship of circulating lymphocytes and monocytes to breast cancer response, and being active with community engagement, inclusion, and team building. We were, of course, absolutely delighted when Sarah matched with us in 2020. And she's been just an absolute joy to have in our program since the very beginning. Her enthusiasm, her passion for clinical care, and her kindness comes through on every rotation. She's continued her longstanding interest in clinical trials and is working with the inflammatory bowel disease team here at Stanford. And we can't wait for her to bring her many skills to the chief resident year, a prelude to a planned future fellowship in gastroenterology. So please join me in, and maybe if they could stand up and we can all give a round of applause to the 2023-2024 Medicine Chief Residents.
Thanks so much for that wonderful introduction of our new chiefs. We're so excited for the takeover next month, but we're very sad to be leaving. We've had such a wonderful year, so thank you so much for all of that. We just want to quickly introduce and give our clinical decision-making awards. This is a award that is given to several residents each year. We usually solicit nominations from the residency class as well as faculty across the different sites for residents who have shown superb clinical decision-making or spent extra time to change the course of a patient's trajectory and make an impact on patient's life and patient's hospitalization. So I'll pass it off to introduce our first awardee.
Fantastic. Thank you all. I'll try to keep it brief. We'll go through each of our awards. So our first case for our first award is a case of a 69-year-old gentleman who came in with multiple comorbidities, primarily a recent MSSA infection, who came in with confusion, and he had a relatively uncomplicated initial hospital course where he came in with altered mental status, a bit of hoarseness, had a very broad workup sent, and CT non-contrast imaging because of an acute kidney injury, showed some cervical adenopathy, and he was primarily in the hospital awaiting improvement of that kidney injury before getting a contrasted CT or other studies to evaluate that adenopathy. So it really sort of felt like clinically it was on autopilot. And then on routine morning rounds the next morning on hospital day 8, the intern on the team noticed an acute change in anterior breath sounds that was very subtle but potentially consistent with faint stridor. And they decided to call ENT urgently to advocate for bedside laryngoscopy. The ENT scope showed severe diffuse edema of the supraglottis with a narrowed glottis. And they were taken urgently to the OR for awake fiber optic intubation. So I want to congratulate and read some words from the nominator for our first awardee, Dr. Renee Singh McIntyre. So the nominator wrote that Renee noticed an incredibly subtle exam that many physicians may have missed, and this saved this patient's life. If it weren't picked up, this patient may have lost their airway within hours and potentially coded and had a worse outcome. And they were in awe of not only the exam finding, but the conviction and confidence with which Renee was able to go to ENT initially and really advocate for what was best for this patient. So I just want to take a moment and say congratulations to Dr. Renee Singh McIntyre.
For our second award, the winner took care of a patient that was a 68-year-old man with multiple comorbidities, including polysubstance use disorder and really struggling with homelessness. He'd had countless recent ED visits and admissions for complaints such as headache, cough, and placement. And he'd been discharged with orders to go to shelter, but unfortunately had never followed up on care. During the last admission at our hospital, our winner went above and beyond to secure shelter for him and to fill out paperwork that's usually taken care of by primary care providers to advocate for the fact that our patient's homelessness was exacerbating his medical conditions. This award goes to Dr. Alec Hasty, who with his work not only had this patient placed in a shelter, but the patient actually recently received a housing voucher, which is a huge life-changing event for this patient. And we really appreciate the care that he gave him, the effect that he had on the course of his life. Congratulations, Alec.
It was a big deal. Yeah. So for our third award, the case was a 68-year-old female who presented with bilateral lower extremity pain and swelling in the setting of COVID diagnosis a couple of weeks ago. In the emergency department, she was found to have subsegmental right lower lobe pulmonary embolism and was admitted for initiation of anticoagulation. The admitting resident came to evaluate her and noted on her history that something sort of didn't fit, and examined her extremities and found them to be cool, and that he couldn't detect any pulses either by palpation or Doppler. He was conserved for critical limb ischemia and contactive vascular surgery ASAP. And CT angiography in the meantime, while they were mobilizing the OR, showed occlusive thrombus within bilateral popliteal arteries and calf muscle edema bilaterally. This patient had to undergo bilateral 4-compartment fasciotomy with return of circulation, and this patient had bilateral compartment syndrome, and unfortunately ultimately required bilateral above knee amputations. But this award goes to Isan Ekpo. Dr. Ekpo demonstrated consideration for the whole patient and was able to override the tendency to anchor to an established diagnosis. In this case, it was a pulmonary embolism that had been diagnosed in the emergency department. His attention to the patient's symptoms and physical exam led to a change in her clinical trajectory and expedited the involvement of the surgeons and to rapidly diagnose and treat her ischemic limbs and gave her the best, this is getting cut off, but gave her the best possible chance to avoid further progression of this. So congratulations, Dr. Ekpo. And I'll hand the mic over to Dr. Dunn.
Good morning and happy AAPI Heritage Month. I want to give a few quick announcements. Number one, we have announced the next discussion for our 1619 project. That will take place on May 31st at 5 p.m. It will be a virtual discussion of episode 2 of the 1619 project. Hope to see you all there. We'll have the link put in the chat for registration. Secondly, tonight there is a Black Brilliant Showcase, a creative arts showcase that will be happening right upstairs in Berg Hall, where Black faculty, students, and other members of healthcare professions will be performing and showcasing their creative talents. And I will save some other announcements for the HEAL OFDD sessions that will be coming up for next week. Thanks so much, and I will hand it over to Dr. Salas.
Thank you, and let me just take this off. I don't want to hold us up for too long because I know we've had a lot of announcements today, but we did feel it was important to acknowledge what's happened in the news this week, that we have the Supreme Court documents that were leaked on Monday, foreshadowing what was otherwise an expected decision to come out this summer, overturning Roe versus Wade. And the reason we want to acknowledge that here is because it affects everyone in this room and in our audience and in our department. And as a leadership team, we feel it's really important to recognize this moment, to validate whatever emotions people are feeling, because they are all okay, and to assert that abortion is healthcare. And it's healthcare for our patients, it's healthcare for our colleagues. We have data we just published last month showing 1 in 6 medical students have abortions, and over 10% of our colleagues, either them or their partner, has had an abortion. If people are looking for resources, we did send out an email yesterday that came out from our entire leadership team that has some links in there, including places where people can donate if you have the means and are interested. And we're all available if anybody has any other suggestions for what we can do, because we are very committed to doing everything we can to ensure that people have continued and expanded access to abortion, both locally and nationally. And with that, I'll turn it over to Dr. Herman.
Thank you, Dr. Salas. Just to briefly mention this lecture with the Department of Health Policy and their Health Equity Lecture Series, and then to mark Asian Pacific Islander Heritage Month. Next slide. Thanks. That the Asian American Center on campus will be hosting multiple events. This is just in reference to the Cantor Art Museum, which is featuring several works by Asian American artists, and we'll have more announcements in the newsletter and this coming week. Lastly, upcoming grand rounds next week will be, next slide, Dr. Fumiko Chino. She is a radiation oncologist at Memorial Sloan Kettering, speaking on financial toxicity and cancer in America. May 18th will be Dr. Amy Abernethy, who is the Principal Deputy Commissioner of the Food and Drug Administration. And then May 25th will be Dr. Anekwe Onwani, who's a professor of medicine and the chief of cardiology at Morehouse, and he'll be speaking on health equity and design of heart failure management for safety net hospitals. And we'll pass it to Dr. Marin to introduce our speaker.
Thank you, Dr. Harmon. So, pleasure for me to introduce today's Medicine Grand Round speaker, Dr. Michaela Kiernan. Dr. Kiernan is a senior research scholar at the Stanford Prevention Research Center in the Department of Medicine. She received her master's and PhD in social psychology from Yale and was a postdoctoral fellow at the Stanford Prevention Research Center in studying cardiovascular disease epidemiology and prevention. She is funded by the NIH and the American Heart Association for her research on behavioral interventions for weight management. She has served on numerous committees for the NIH and the American Heart Association, including as a standing member of the NIH Psychosocial Risk and Disease Prevention Study Section and co-chair of one of its study sections, and as a member of an NHLBI Special Emphasis Panel. In 2009, she was awarded the School of Medicine Postdoctoral Mentoring Award, and she was awarded the SPRC Divisional Teaching Award on 3 separate occasions. Dr. Kiernan has taught a research methods course in the School of Medicine for the past 15 years. She currently directs the school's Office of Faculty Development and Diversity R01 Countdown program, an intensive grant writing boot camp for junior faculty that has generated $125 million in first-time NIH R01s and other grant awards since January 2013. The title of Dr. Kiernan's talk is Innovative Strategies for Enhancing Participant Retention in Randomized Trials. Dr. Kiernan.
Thank you guys very much. It's a pleasure to be here. And thank you very much for the introduction, David. Today, I'm going to cover innovative strategies for enhancing participant retention in randomized trials. I'm going to talk about 4 things that I'll use as an outline. One is sort of why do we care as clinicians about retention for clinical trials? I'll talk about the state of the existing science around retention strategies. I'll talk about some innovative ways we've gone about trying to enhance retention in our own trials, predominantly behavioral weight loss trials, and I'll end with some resources. So clinicians need answers to crucial questions when they're in clinic. So in cardiology, you want to know sort of what types of therapies you need for patients with type 2 diabetes that might
prevent hospitalizations for heart failure, for critical care, you might want to know. For patients with ARDS, what types are the optimal levels for mechanical ventilation? And then for infectious disease, what types of therapies could reduce the severity of COVID? So to do this, excellent, clinicians don't have enough time to sort of sort through the evidence. So excellent clinical care is informed by evidence-based clinical guidelines. These come up and are updated pretty frequently, including the ones for heart failure, which were about 2 weeks ago, and the COVID ones within the past month. But these guidelines themselves then are informed by the methodological quality of the evidence. And so, for instance, for the recent ones for heart failure, the quality of the evidence is basically rated from different levels, from sort of really good to less good. And the level A quality is based on high quality RCTs, preferably more than one. So, what makes a trial high quality then, given clinicians need to lean on the high quality ones, yet the majority of ones in medicine are not high quality. So what are some of those characteristics? And one is having sufficient statistical power. So this is a reasonable chance, say greater than 80%, that you would detect the treatment effect if the effect is there. But despite sort of new regulations where we need to pre-register clinical trials, it's still many of the trials in medicine are underpowered. So they'll unlikely even to be considered when thinking about these clinical recommendations as level A evidence. So we're sort of curious, would a more practical understanding of statistical power be helpful? So we came up with an illuminating analogy for statistical power. So imagine you're lying in bed one night and you hear the distinctive hoot of a great horned owl, and you get up with your pen light that you use for reading at night, you shine it out the back door, trying to find the owl because you've never seen it before. And unsurprisingly, you can't see it because the light is so small, and so you would miss the owl out there indeed if it's there. But then you grab your hefty, powerful light that you use for walking outside, and you shine that out the back door, and lo and behold, you can see the owl staring down at you from the tree. So in this analogy, the sample size is the amount of light that you use to see. For the size of the owl is the effect size, and then the probability that you'll see the owl if it's there is statistical power. And so it's important to recognize that the amount of light doesn't actually affect if the owl is there or not. It's really just affecting the probability. So unfortunately, the majority of clinical trials that we see in the literature are little bitty pen lights trying to chase down adorable but very small baby owls, right? So this is a problem because it's the futility then of underpowered trials, right? So you're sort of going up against something no matter how well the rest of your trial works, you're at a luck. So let's say, okay, then again, maybe you've got a large sample size, you've recruited a large sample size, and you've got a large owl, so you feel like you're sitting pretty well. Yeah, but unfortunately, that flashlight that you had, that really one with a lot of light, sort of has some dying batteries, right? So over time, you're less able to see the owl, and that's sort of the equivalent here of poor retention over time. That's what I'm going to focus on over the next half hour or so. All right, so there's standards in the field about what sort of good levels of sort of appropriate minimal levels of retention. So BMJ has best practices out there for say 80%. Otherwise, sort of your statistical assumptions start to sort of unravel if you've got less than 80%. But there's also some other issues underneath that. So this would be an ideal situation where you've randomized people, you have sufficient numbers at the start of the trial. They're not different by randomized arm, they're not different by key subgroup, but that's not really sort of reality. So right, again, similar to what I mentioned about the dying batteries, oftentimes you don't get up to 80% power. So right off the bat, you're sort of behind the 8 ball. And there's two other issues that can happen here. One one is they can be different by randomized arm, right? So you have more people in this case, say, coming back for the treatment arm. And then the other problem is that they can be different by key subgroups that you might really like to see, especially as clinicians. Those are the people for whom you're really particularly interested in. So there's really two issues then. You're sort of unclear if the treatment effect is due to either the treatment or the people who came back to be assessed or were retained. And then the second problem is that the treatment effect then is unknown for these key subgroups, right? So when you go to apply these recommendations, it's not based on data for people for whom you care about the most. Okay, so sort of three key subgroups we're particularly interested in. So one are people with more complex medical conditions, similar to what you see in clinical practice. So that might be people with multiple comorbidities, or it might be people with chronic pain. The other is individuals who are historically underrepresented in trials, and in the past that's been sort of mislabeled, inappropriately labeled as hard to reach or hard to retain, when in fact, the onus is on us as researchers to figure out how do we best support people and enhance retention for these groups. So these different groups could be people from particular race or ethnicity groups, such as people of color, less education, less income, perhaps language spoken. And then another group that we're really are important is to make sure we retain them are people who are less successful at the target outcome, right? So for the behavioral weight loss trials that we do, those are people who have trouble losing weight, right? Or have trouble maintaining weight. And in fact, those are the people we can learn the most from, for whom a program did not fit. So we want them to come back because we'll learn a lot from them. So what's the state of the science, specifically the experimental science? Just out in January 22, retention sort of research in general has not been a focus until very recently. It's been more on the front end, on recruitment, rather than retention. So a group has developed sort of a database of all the different studies that are out there around retention, as well as a framework. But if we sort of hone in on what the experimental work shows, we're not left with a lot. So basically, of the 38 embedded trials, so right, if we want to test retention strategies, the sort of ultimate test, the gold standard test, to embed them in larger trials and see if you see an effect on retention, right? So there's only a few of those out there, and most of the trials have evaluated either reminders or incentives. So basically, sort of bribes and bugging people, right? So those are sort of 60% of the trials are looking at that. But that kind of makes us step back and say, what exactly are we trying to enhance when we're trying to enhance retention? And so if you sort of dig a little deeper in terms of some of the challenges that people face when they're trying to decide if they want to do a research trial, there's a lot of ambivalence. And by ambivalence, I don't mean wishy-washy. It means sort of simultaneous and contradictory attitudes or feelings towards something. So we see these types of this ambivalence in a number of different levels with clinical trials when people are considering whether to do them. So one is being in a research trial at all. Right, so some of the horrific transgressions against particular communities, such as Tuskegee, really it's sort of visceral anger around whether or not they should consider being in a research trial. Another is being assigned to a particular study arm. So a researcher might be really excited about the treatment group, but in fact, the participants are focusing on the 50% chance that they'll get the other arm. Participants could resent or resist being told what to do in terms of changing target behaviors. And then there's a contradiction between sort of their initial expectations. Oh, maybe this is the time I'll lose a lot of weight, and then what actually happens during the trial. So ultimately, this comes down to trust, right, between participants and the team. So our team has developed an approach we call the methods motivational interviewing approach. I'm going to talk about what the approach is. I'll describe it, and then I'll go through some of the evidence that we've accrued over the last, say, 15 years or so. So basically, we put out our first article around this around 2005, just wrote up sort of the entire framework and published that last fall. And it focuses on sort of one major approach here, and that is interactive orientation sessions. And we do sort of a number of different things. I'm going to concentrate on two of them. And one is we actually share the scientific rationale behind the methods. So we tell participants the why of why we're asking them to do particular different things. And then the second is we actively work to diffuse that ambivalence around participating in research trials. So deal with that explicitly and do that with motivational interviewing techniques. So the sort of underlying philosophy of these orientation sessions is we consider participants as partners in research, right? This is informed and in fact sort of inspired by community-based participatory research. And there's a series of principles that they have. And one of them is sort of promoting a co-learning and empowering process, right? So the idea here would be to increase sort of community capacity, specifically here around research, as participants are considering whether or not they want to be in a trial. And this is particularly important for people who are less familiar with research. And then the other sort of piece about the orientations is we try to be really explicit about the trial expectations. So we don't ignore them. And that comes on two sides, right? It's what's in it for me as a participant, and they need value out of what they're going to do. And then the second is that we clearly acknowledge the trial challenges that they're going to face and not hide them under the rug. All right, so I'll talk a little bit about how we go about diffusing the ambivalence. So during the sessions, when we bring people in, we initially started these with in-person ones, and now we have them in a variety of different online formats as well. We put up on the board, on a whiteboard, so it's very interactive. When we bring in a group of people who are thinking about being in a study, and we do this well before randomization, okay? So a couple weeks before a program may start. And we put this up, and on the left side, we have whether or not they're in the trial, the other one not in the trial, and then these kind of pros and cons. So then we break people up into groups of 3 and 4, and the small groups then generate the pros and cons. This encourages a lot of interaction and sort of buzz in the room as people are getting to know each other and coming up with these pros and cons. And then the facilitator then leads a discussion with the whole group where they systematically elicit the responses from all the different groups and from each and every group for each cell. Okay, so it might look something like this. We'll start in the bottom one here for cons. So they might come up with things like it's unstructured, it's no direction, I don't get any social support, my health might get worse. Then when we do the next one, so they get to eat what they want, right? So that's pretty important. No one's hassling me. I can lose weight my own way. The next one, they might learn new information. They may lose weight. Accountability. I can tell you that health science does not come up very often. And then here, they don't choose the program. There's traffic, and so on. Okay, so then sort of debriefing that sort of airs all the pros and cons that people may not have thought of before they sort of walked into the room. You as a researcher want to be really thoughtful about what that choice point is for the two columns, right? So in a lot of cases, it's to be in the trial or not be in the trial, but depending on those trial conditions, you may want to use that as the choice point if you get randomized to one condition versus the other. If you've got particular conditions that are pretty lopsided, you want people to sort of think those through well ahead of time. And there was a NIH expert panel that put out a really good paper on selector of comparators, sort of different stages of research. All right, so it's really important for the facilitator to avoid a pro-change position. In other words, this is the opposite of a hard sell. Right? They want to put the sort of ideas out there and let people have them. So we elicit an equal number of responses in each of the cells. So you may pull for a little more responses to make sure that happens. And then two important things here, you focus on 2 critical cells because that's the crux of this working in terms of establishing trust. So the first cell, you just do it to sort of get people going, but making that second one, talking about the pros of not being in the trial, is where you as a researcher sort of set your credibility, that you're open to it, you're hearing it, you're not shutting those down, right? And you're acknowledging that indeed you can eat what you want, you're not going to get harassed and so on. And then to the third, and then we end purposely on the cons of being in the trial. So in other words, again, trying to make sure this isn't a hard sell. And then finally, we finished with the big picture to really put explicitly sort of put the decision-making on participants, that they'll make an individual decision in terms of how they're going to weigh the pros and cons. And then finally, we asked them at the end to make 2 commitments. One is to themselves, if they're going to be, say, in a weight loss trial, that they're going to kind of give it their all for their own particular effort. And then importantly, to the scientific quality of the trial. So that's not to science, that's this particular trial. And that they'll complete all the assessments regardless of their own experience, right? Regardless if they're successful or not in terms of losing and maintaining weight. All right, so if you kind of dig a little deeper into the debrief, there's another layer of things that are going on during these, and that is the key subgroups that you may be interested in recruiting and retaining are represented from the start. So if your stated goals, for instance, might be to recruit a sample that's reflective of the diversity of the local area, such as 50% men, and because a lot of men are not in weight loss studies, and 50% of color, that's already evident in the room, right? And then importantly, how the nature of the interactions, that perspectives from members of key subgroups were actively solicited and taken seriously during the process. So this is applicable to all kinds of trials. It doesn't need to be group-based interventions. Again, what you're trying to do is enhance the idea of contributing to the quality of the trial. So you could do these group-based orientations for individual level interventions. All right, so let's talk a little bit about the evidence that we've started to accrue around this. So in this case, there were 3 weight loss trials. These weren't ours. These were other teams that were conducting weight loss trials. One was called Shine, one Get Social, and Glow. And they looked here, I've sort of summarized. There was a control group and an intervention group, and they looked at different types of interventions, right? They had a mindfulness one. They were looking sort of online digital experience. And then the Glow was a trying to prevent weight gain in postpartum women. So each of these trials early on had signs of either poor or differential retention. Okay, so this is the table that I'm going to show, and now we'll kind of fill it in for each one of the trials. Again, the outcome here was getting weighed sort of well along 18 months, 12 months, you know, at the end of the trials. So early on, the Shine trial, you know, for the control group, only saw 58.5% of the folks coming across the finish line, and 75%. So they had both poor and differential retention, right? They didn't hit that 80% mark. Get Social was a little under the 80% mark, and again, differential. And then in Glow, this was done at Kaiser Oakland. They have higher criteria. They want to get them at 95%, and they were distressed to see it was under that bar for them. So given that, they were concerned. So these were the initial cohorts that came through on the trials. So they called in the Ghostbusters. So one of them was myself, and the other 2 people were folks who had been on our team, Danielle Jake Schaffman, who's now a professor at University of Florida, and Dr. Susan Brown, who's an associate professor at UC Davis Medicine. So each of us came in with a different format, but using the same kinds of principles that I mentioned. So I did in-person with Shine, Danielle did webinar when web chats, and Susan did conference calls, kind of group-based conference calls with each of these groups. So what happened when these got into play into the remaining cohorts, right? So here, again, just wanted to make the differentiation between initial and with orientations. So after implementing these orientations, you saw that the retention came across the 80% mark and lost that differential. And indeed, it went up by about 17.3%. In Get Social, they really pumped it up to about 95% in both of the groups. And then in Glow, they got up to their 95% that they were shooting for. They were already sort of on the ceiling effect there. So each of these trials also promoted, by doing the orientation sessions, they also promoted higher attendance at the 2 different interventions on each side. So for both the control group and the intervention. And importantly, the orientation session did not affect demographic characteristics, right? So we didn't lose those key subgroups along the way as a function of implementing the orientation sessions. Okay, so, all of the work that I've talked about so far is on weight loss, but, there's a lot of other populations, people want to come to your trials. Maybe that's the reason why this is working. But there was a trial where they tried an interdisciplinary team-based care for patients with chronic pain. So a lot of part of that care was around reducing depression, and they were looking at it on the effects of long-term opioid treatment and primary care. And this was a mouthful, an effectiveness implementation hybrid cluster randomized pragmatic trial. So they looked at it in Kaiser Northwest, Georgia, and Hawaii. Again, they sort of early on ran into problems with early and differential, poor and differential retention, and put in-person orientation sessions. So the data looks like this. Again, for Kaiser, they wanted up around the 95% level. They weren't seeing that early on, implemented the in-person ones, and was able to see a large difference. And that trial across all the sites indeed showed a significant effect for this team-based care. All right, so that's sort of a broad, these orientations, a lot of moving parts. Ideally, it'd be nice to sort of hone these down to specific strategies so that you could implement a couple of them, in smaller trials rather than sort of maybe the whole piece here. So I'm going to now focus on the other piece that we really do in the orientation sessions, and that is sharing the scientific rationale behind the trial methods. So for here, one of the questions that we raise actively, sort of explicitly with participants when they come to the orientation sessions is, why is it so important for people to come back to clinic visits, right? So we have a discussion about that. And so we developed a question that we could use in studies that would pick up whether or not people realize the impact of dropout on retention. So let me just give you a minute to skim through that. So imagine people are in a new online program to help them eat more fruits and vegetables. They're asked to fill out a survey at the end of the program so the evaluation team can see if the program worked. Now imagine the people who did not eat more fruits and vegetables by the end of the program did not fill out their surveys. How would this affect what the evaluation team would conclude about the program, right? So it'd make the program look more successful, less successful, or no effect. Right, so we're sitting among a group of people here, and here who probably would be like, well, of course, it's more successful. But what do you think either your patients or your participants would answer to that, right? Especially if they didn't have a background in research. So we went out to see what do people do? Do you think it's going to be 40, 60, 80% of your patients or participants would get that question right? Would sort of fundamentally understand why that's so important. So we went and did this. We're working with we ran some experiments in a crowdsourcing population. So these are basically sort of professional survey takers. And so they're used to filling out a ton of studies very quickly. They get paid sort of on how quickly they move through things. So we gave them this question, and about 2/3 of them got the question right? And then we also did it in a large fruit and vegetable trial where they recruited people, young adults in Detroit and young adults in rural Pennsylvania. About 60% of the people got that right. So a little room for improvement there. So what we did is we came up with a infographic letter where we got across 4 constructs, our goal here, and it was 1 page, something that you could put online, something pretty easy to sort of bring people up to speed. And we tried to do 4 things with this. One was the knowledge of retention. So to get across the idea that researchers want a true picture, but that poor retention distorts the trial results. It gives you the wrong conclusion. The second was a sense of transparency. In other words, researchers want a true picture, so they're willing to hear negative information. They're willing to hear a program doesn't work for people. The value of retention. So this is sort of the importance of a particular participant contributing to a true picture, regardless of their own experience, right? So their data is valuable, regardless of whether or not they were successful at losing or maintaining weight, eating vegetables, or so on. And then implicitly, the trust of the research team. And here in the letter, we never mention the word trust, but ideally, if we're doing these sorts of things, the trust may increase. So each of these constructs are matched to a sentence in the letter. Okay, so what we found is we were able to get it from 2/3 to over almost 90% of the group after reading this letter got the retention question right when they were randomly assigned to these two conditions. Now, what about those other constructs that we were interested in? Indeed, we saw those go up in folks who read the infographic letter. So they were more likely to see the team as transparent. They had a higher value of retention regardless of their experience, and more likely to trust the research team. So these are important things, but you also don't want to have a couple other things happen. And that is, you don't want giving people a retention strategy to sort of differentially affect whether or not they want to do the outcome of the study, right? So giving people something for retention, you don't want them to suddenly want to lose weight more or eat more vegetables, right? You don't want to influence that. So we asked people sort of the value of the study outcome. In this case, it was eating fruits and vegetables, and sure enough, did not show a difference between these two groups, right? So reading the letter did not make you want to eat more fruits and vegetables. And it also didn't affect your personal sense of commitment to sort of follow through on things. Okay, so we replicated this across 3 experiments, but it's also really impactful to sort of read what people sort of think about this. And in every study we do, we always add 2 questions, which is what do we do well and what can we improve, right? So, and we do that in a large clinical trial, we do that at multiple stages. So we make sure we sort of have a pulse on how people are, what people are thinking about on the study. So we did this at the end of the infographic study for the groups. And we're pretty surprised in this context what came up. So this infographic letter is a very good idea. I can think of a number of programs offhand that I stopped participating in because my embarrassment about my results. With this type of clear explanation of how my behavior affects the researcher's experiment, I would be more likely to continue. Here, I never thought about the results before of how they could be so wrong if everyone didn't participate. So that was eye-opening for me. Thank you. The wording on the letter painted a clear picture of needing information without making someone who didn't eat more vegetables feel guilty. And then finally, great study. Nice to read about ethical organizations for a change. Okay, so those were just spontaneous comments in the back where we're sort of expecting, you need to make sure there's a counter or something on the survey and so on. So, okay, so in terms of our ongoing work that we're doing, we were just recently funded by the Stanford Cancer Institute for an innovation award, and it's a three-part grant that we're going to do. So we're going to conduct what are called most optimization trials with crowdsourcing participants. I'll explain a little bit more on what that is, but it allows us to take a few more of the elements that we think might enhance, a few more strategies that might enhance retention, and test them out in these populations before we would put them, test them out in other ones. And then secondly, we're going to interview clinical researchers and as well as patients with cancer and get their feedback about the types of strategies that we're developing after we've sort of gotten out the bugs with the first groups. And then our goal here is to really disseminate this online retention package so that other folks can embed and test it in their clinical trials, right? So again, these types of strategies are designed to go across many different types of trials and need to be tested. So a little bit more about the most optimization. This is a really elegant, efficient design. So I've done an example here for 3 strategies, but we're planning to do it for 5. So people basically get randomized to either get a strategy or not. So it's either on or off, and it allows us to test every possible combination for each of the different strategies. But then you can also collapse across a particular strategy and test whether or not one strategy versus not getting that strategy influence, say, the types of mediators that I mentioned before, including trust and other ones that might be specific to these particular strategies. So we wanted to make sure, so again, given this was funded by the Stanford Cancer Institute, that made us think more broadly about multi-site trials, given many cancer trials are multi-site, clinical researchers doing these trials may only have a few patients or potential participants per site, and there's many and very widely dispersed sites. Patients themselves then with a severe medical condition like cancer, they grapple with diagnosis, any sort of burdens, additional burdens then for trial participation. And then importantly here for retention, the sense of isolation, right? They're sort of scattered across the country, especially for rare conditions. So these are the NIH Comprehensive Cancer Centers. Obviously they've done their very best to try and reach a lot of different states. It's not randomly sampled, but they are trying to get a lot of sites. Ideally, we would try and do the same thing with our crowdsourcing platform so that we could, sort of test this out, some of these strategies initially. So we conducted a pilot study with the crowdsourcing, and what we found was that of our 61, we sort of got 24 of the 50 states just with the 61 folks. And the key subgroups that we're particularly interested in were represented. So we specifically sampled for these types of people. So these were about half the sample was between 25 and 34 years old, half were women, 43% were from more than one race and ethnic group. About a third of them, their highest level of education was high school. About another third, their household income was less than $25,000 a year, so that's $12 an hour. Over a third had 2 or more children, and then over half of them lived in rural or small city and towns. So it's a really ideal sample to be sort of getting feedback. They're used to giving feedback, so we're pretty thrilled about that. All right, so future directions, retention strategies, again, sort of the crux of this is to embed them and experimentally test in larger RCTs. And again, our real focus here is how best to retain the key subgroups, both to ensure representation and generalizability of trial results, but really ultimately to inform, excellent clinical care for these patients. I want to provide some resources in case you're interested in trying some of these ideas out in your own studies. So there's some resources available now and then both in the future. So if you would like some of the PDFs, either of some of the other team studies that we've mentioned or some of the work that we've done, you can send an email to healthyheart@stanford.edu. And then once that online retention package is available for people to try out, we'll send another email out letting it know that it's available. Finally, I'd like to leave you with some kind of inspiration, which is the approach that we take on this, we think is a way to be sort of ambassadors for science, right? So our hope is that by going through the process with participants and giving them the skills and the tools to be able to decide whether or not a particular trial would be a good fit for them when they're working working with us, our hope is that they and their families then have these tools to be able to evaluate whether or not other trials in other areas might be a good fit for them as well. So thank you guys very much. Great. So just to repeat the questions, so one of them is sort of like how many people might you lose as you go through this process? It's going to depend a lot on the trial, right? So the trial that if it has a lot of hoops that you're having them jump. So for instance, in our things, they're pretty comprehensive behavioral weight loss programs. We're going to lose some. So we keep typically about 2/3 of the folks that go through. And a lot of people, it's because they have vacations or something like that. So we pick them up later in future cohorts. So I don't think it's and then also sort of keep it in the perspective of how many other things we have people do to go through trials, right? So to put whatever percentages we lose, match those to, they also have to take 2 tests and they also have to do this and they also, sort of all the other things. So great question. And then the second one was, how would you do an inpatient? I think sort of going with sort of the webinar web chat ideas, you're saying inpatient in that you would lose them then. Yeah. Yeah. It's kind of like you're at the yes. Feels like, yes. It's probably something you don't. Yeah. No, great. Exactly, a little gentle push, yes. You know, I think in that case, maybe coming up with a short video where people like them are having this discussion, right? It could be a 2 or 3 minute video where you could have people, you know, view it before you come in to talk about the study. Here's sort of all the things that are good, and here's some of the warts about being on it, something like that. Yeah, great. Thank you very much.